Hello everyone, my name's Wendy Hoskins. I'm General Manager Health and Disability at Enliven for Presbyterian Support Northern. Welcome to our conversations about dementia. Today I'm introducing to you Ruth Thomas, who is a 30-year dementia care expert. She's a psychiatric nurse who's worked in a number of different settings, including managing a 120-bed care home. She's also managed hospital services and managed services in the community, as well as working for the Ministry of Health. Ruth has a Master's in Dementia and an MBA. She's our dementia lady. Welcome, Ruth.
Thank you, Wendy, and I'm looking forward to these conversations. And thank you for reminding me of my title, Dementia Lady, because I'm actually very proud of that.
Ruth, you've spent 30 years working in dementia care. What made you get into it, and what changes have you seen during this time?
30 years is a long time, eh? And it's a long time to be driven on one particular path. And the reason I got into dementia care was not for good reasons, unfortunately. It was because when I qualified as a psych nurse 30 odd years ago, dementia care was pretty atrocious. There was no care. People with dementia were looked after in the big psychiatric hospitals because there were no other places for them to be cared for. And they were almost treated as non-people. They were seen as nuisances that had behavioural problems, who had to be told what to do and how to do it and when to do it. They were not seen as people. They were seen as empty vessels to wash and change and feed and take to the toilet. So unfortunately, for that era, that was quite normal because there was no recognition about the person behind the diagnosis. So what got me into dementia care was wanting to do something about that, which at the time shocked everybody that knew me, that I suddenly became this very outspoken person on behalf of people with dementia, because I was incredibly timid and shy. So from all those years ago, basically I've just kept this desire, I'm not entirely sure where it came from, to improve the lives of people with dementia.
So if you're comparing and contrasting the experience at the start of your career with where things are now, where do you think they've moved to now?
They are hugely improved. There's a much better understanding about dementia and how it affects people, and that it is affecting people, that people diagnosed are still people, but there is a huge way to go. We are going in the right directions, but there is also a lot of ill-informed care and a lot of misunderstanding about dementia. And some of the things that I see that can improve relatively easily is the terms and the words that we use around and with regard to people with dementia. So unfortunately there's still terms like sundowning used, people who've got challenging behaviour, they're demented, which are all very depersonalising.
So what should people use instead?
So instead of demented, somebody living with dementia. So I kind of liken it a little bit to help people understand, is if you're diagnosed with cancer, nobody says, oh, that person's cancerous.
True.
With dementia, I think it's all right to use the diagnosis as a derogatory term. With sundowning, it's a term you will hear used a lot, but to reflect what's happening for the person, it's late afternoon agitation, which explains. So when people say to me, or so-and-so sundowning, I will say, well, what does that mean? I don't know what you mean. What are you talking about? And that helps them explain what's happening, which is the person is agitated or distressed, and it's later afternoon. With challenging behaviours, then we look at it very much from the point of view of the person with dementia. So again, looking at what is driving their distressed behaviour, what are they trying to tell us through their distressed behaviour, and to move the focus away from the person with dementia to somehow be able to not have the symptoms that actually got them diagnosed, to saying what can we do, what can we change to help that person be less distressed, rather than telling the person you have to stop doing this symptom that you have because of your diagnosis.
Excellent. So What do you think is needed though now? If you're looking for the next 30 years, what do you think us as a country in New Zealand needs to do to move from where we are to where we should be?
One of the big things is recognising that dementia is complex. So unfortunately, a lot of people think that somebody with dementia just has a little bit of memory loss without understanding that it's all areas of the brain that are affected, and therefore all areas of functioning, including sight, how you hear, how you experience touch. Again, a lot of people think that dementia care is somebody's had a good idea and it kind of works, so that's what we do, without realising there's a huge amount of research and study behind dementia. So I think formalising that that the approaches are research-based would be great. So expansion of the Masters in Dementia would be great. I did mine primarily to demonstrate that what I was saying was not just a good idea that I had, that it is based in evidence. And I've forgotten what you asked.
Ruth, you've spent 30 years working in the field of dementia. What changes do you think you'd like to see over the next 30?
Probably one of the biggest changes I'd like to see is that people with dementia have their voice heard. Currently they are invisible and they are hiding away, and I'd like to enable them to be listened to and genuinely heard.
You work with people with dementia on a daily basis. What are some of the key needs that you think need to be available?
Well, to help those that wish to remain at home, which is most people with dementia, one of the key things is having respite that genuinely enables their primary carer to have a rest from the caring role. For the person with dementia, the primary need is to support them to live well with their dementia and not die from their dementia.
What do you feel are the next big steps required in dementia care?
I would say almost treating dementia professionally and support-wise as you would somebody with a diagnosis of cancer. So if you're diagnosed with cancer, you are given supports and advice every step of the way. For those with dementia, generally somebody is diagnosed and then they are left to flounder with little advice or support until a crisis happens, and then they're brought back into health system. So I think a full wraparound service from diagnosis right through to death would be a marvellous step forward.
So Ruth, dementia lady, what would your legacy be?
My legacy on a personal level would be that those with dementia are saying that I helped them live well with their dementia, and the support I gave them was genuine and long-lasting. On a broader level, I think the service like EnlivenPlus, my biggest legacy would be EnlivenPlus was not a gold standard service that was seen as unusual. It was just the everyday support that people with dementia were offered.
Fantastic.